This is video number 3 on our Alterations in the Endocrine Function series, and we're going to be talking now about the thyroid gland and the problems that the thyroid gland causes. Hypothyroidism, also known as myxedema myxedema, and then hyperthyroidism, also known as Graves' disease. If you look at the thyroid gland, you can actually sometimes feel your thyroid gland. It consists of two lobes. If you feel your trachea, the thyroid gland kind of sits behind the trachea on either side, just below the thyroid cartilage, and it produces hormones that stimulate metabolism. So someone who has hypothyroidism will be kind of slow to function. And then someone who has hyperthyroidism is fast, high metabolism. This person will be warm most of the time. They will be thin, might have problems sleeping. Whereas hypothyroidism, they might have trouble losing weight, not have any energy, so on and so forth. If you look at the thyroid hormones, there's two, T3 and T4. If those hormones are increased, then metabolism is increased. Hypothyroidism is there's just not enough secretion of T3 and T4, so the metabolism slows. It's usually caused by, the primary cause is a thyroid dysfunction, and then the secondary cause is a pituitary gland dysfunction that isn't stimulating the thyroid gland to produce thyroid hormone. If there is a decrease in thyroid function in infancy or childhood, it can result in creatinism, which can lead to mental retardation, disabilities, and dwarfism. You don't see it a lot in kids, but it can happen. What you're going to find is, just imagine everything about the body slows down, and the skin dries, lack of energy. There can be cold. The heart rate's decreased. They might swell up. There's no tolerance for cold. Their sweat glands might not regulate properly. Females are going to have problems with their cycles. Headaches, hair loss. Just again, think about everything slowing down. Goiter is an issue with the thyroid where the thyroid actually swells or grows almost like an extra layer to it. And when that happens, you can actually see a goiter. If you get on YouTube or even Google goiter, you're going to see a ton of different pictures of it. Here is a person suffering from hypothyroidism. On the left hand, you see before the treatment. So you can see how swollen their face is, how puffy their eyes are. Now, it's kind of hard with this picture because of the glasses the person's wearing, but just look at the eyelids and how saggy they are because they're so swollen, and how there's no differentiation in the skin, and especially in the neck. Look at the swelling right through here, and then how much better she's looking over here once she's had treatment. To diagnose hypothyroidism, they're going to look at T3 and T4, which will be below normal, so make sure you know normal rates for electrolytes and normal rates for all of these different diagnostic tests. Just know the normal, and then you'll be able to certainly pick the abnormal. T3 and T4 are usually low in hypothyroidism, and the TSH, the thyroid stimulating hormone, is usually increased. And this is because the TSH is high because it's trying to stimulate the thyroid to produce T3 and T4. Medically, It's pretty easy to manage if they can get the cocktail of levothyroxine correct, which is synthetic thyroid hormone. It's taken in the morning. The thing about levothyroxine is you don't want the patient to change brands. There's several different brands. There's generic. So it's one of those drugs that you have to be really careful about changing. And you want them to take it in the morning, usually on an empty stomach. Side effects of the drugs are insomnia, nervousness. So again, whatever the drug is setting out to do, which is to increase the metabolism, it could increase it too much. And then it just has to be, the dose has to be altered. Also, nursing diagnosis. Again, think of someone who has no energy, and let's do a head-to-toe assessment. So neurologically, no energy continually leads to fatigue. Fatigue can lead to depression. Cardiac, low blood pressure, low heart rate. Respiratory. Respirations are going to be dependent on what's going on with the cardiac system, but for the most part, again, things are going to slow down. I think what you're going to see a lot is the GI motility slowing down and constipation. These people are overweight, so you have to put them on a diet that increases, that isn't high calories. However, they like to have high calories because it makes them feel better and gives them, even if temporary, it gives them more energy. They tend to lay around a lot, so they'll have muscle weakness, impaired skin integrity. So again, go head to toe and think about what can be going wrong with this person. You want to teach them the side effects of their replacement therapy, signs and symptoms to watch for. You don't want them to develop hyperthyroidism because of their medication. If a patient has cardiovascular disease, you have to be very careful and use thyroid replacement therapy with caution, because it can cause hypertension, arrhythmias, MI, from a sudden increase. Again, this is medication management is the doctor's job, but it's certainly our job to educate them on what these medications can do and what they can look for. We also want to give them a lot of education on nutrition and appropriate diet so that if they have gained a lot of weight, they can lose it. If they haven't gained a lot of weight, we want them to maintain their weight that's appropriate. Then there's hyperthyroidism. And again, imagine the body moving at hyperspeed. So they have too much T3 and T4. You see it more in women than in men. Primary, again, just like hypothyroidism, is a dysfunction of the thyroid gland itself, and a secondary cause is because the pituitary gland is not functioning well. With hyperthyroidism, again, you could put hypo and hyper next to each other, but you're going to see weight loss instead of weight gain, insomnia versus wanting to sleep all the time, heart palpitations instead of low heart rate, tachycardia, arrhythmias like AFib, SVT, that kind of stuff, nervous and jittery instead of just like wanting to chill out and sleep. Their hands might tremor, their legs might move. They will have a lot of other issues that bother them a lot. And again, just like hypo, you might see a swelling of the neck, which is actually a swelling of the thyroid gland, and a goiter. And here's a picture of someone with hyperthyroidism. See the eyes? And look at how different the eyes are. And you can also see a goiter starting to form here. Now, if you get on YouTube, sometimes you'll see goiters that are just mammoth. So that one's pretty minor. Diagnostic studies are just like hypothyroidism. They're going to look at a thyroid profile and they will see high levels of T3 and T4 and low THS. And again, because THS's job is to stimulate the thyroid to do their job, and the thyroid's already overdoing it. They also, to diagnose it, they will do a sonogram of the thyroid under radioactive dye. So you can see the difference, normal thyroid versus a hyperactive thyroid, and what basically it's reacting to the stimulation of the thyroid gland. Nursing diagnoses. Again, they have anxiety, so what are we going to do to relax them? They're not eating enough because their metabolism is so high they can't bring in enough calories to match it. They can't sleep well, so what are we going to do to help them sleep? Their GI system is on hyperdrive, so they might have diarrhea. They might have a fever. They might be hot. All kinds of things could be happening with them. Again, go head to toe. Monitor cardiac function, make sure they're properly nourished, do what you can to reduce their anxiety, and so on. The thing about thyroid problems, whether it's hypo or hyper, is that they can go to the opposite extreme very quickly if treatments are not maintained properly. And what you don't want to have happen is a bunch of issues where the person becomes so out of whack that you can't get them back into shape, and their cardiac system takes a hit. You will see Tapazole. I think that's probably about the only drug I've ever seen for hyperthyroidism. And it works very, very well. And it blocks how T3 and T4 are observed. You have to continually monitor their cardiac function and their thyroid function so that they don't OD on that medication. Another thing that they do is radioactive iodine, and basically this has an effect on how T3 and T4 are used. Whenever they do a radioactive iodine study, the radioactivity actually goes into the body, and it goes through the body fluids. So you have to make sure that when they use this, whether it's for diagnostic purposes or treatment, that that person is not around an infant. They can't do it on someone who's pregnant. When they come home, they don't want anyone kissing, having any sexual contact. They want to make sure that person is using a toilet that no one else is using because it's radioactive. So anything you can do to reduce exposure is good. Usually with children, they'll say they don't even want the children in the house because the risk of hugging them or loving on them, they don't understand. So they'll want that patient to be separated from children until the radioactivity has left their body. Another thing they can do with hyperthyroidism is they can remove part or all of the thyroid. Now, you remove the thyroid, then you're going to become hypothyroid, but sometimes that's easier to manage than it is hyperthyroid. And the biggest thing that you have to worry about with removing or messing with either the thyroid or the parathyroid glands is a syndrome called thyroid storm. And what happens when you remove the thyroid? Normal surgical complications, bleeding, swelling, respiratory distress, all of those things that you can imagine. But thyroid storm is when your body, because it's in a panic, just secretes tons of thyroid hormone. And when that happens, it puts your whole body into horrible overdrive. The patient usually runs a high fever, and it causes what they call a thyroid toxic crisis. And you'll see on the slides here further, when someone, going back to the surgery, when someone has a thyroidectomy, it's pretty much normal surgical complications. I'm going to start another video because I can only do 15 minutes at a time. I was hoping to get through all this. So in our next video, we'll continue with the thyroidectomy and then go into thyrotoxic syndrome.